Hello everyone. So far we have been doing introduction to FRCR exam. We have gone through the Viva, how to approach Viva and how to approach rapid reporting, how to write long cases. And starting from this webinar, we are starting Radiology University webinar series. This one will be focusing on approach to arthropathies.
So we're starting with arthropathies, mainly arthritis, and I think there's a lot of confusion in exam. Also, you can get like hand X-rays and feet X-rays, and you get really panicked about it or what it is. So it's very important to go through that, and we are divided into mono versus poly because that's where it is. Whether it's poly or mono, there's a different approach to it. So that's the plan. So before we go forward, just let's see the structure of a joint before we go forward. So we got the bones here and the joint space which is here. So this is the articular cartilage you can see, and this is where the articular cartilage and the space left in between is the joint space. So we get a synovium attached, like the synovium is attached to the joint in the periarticular region, not exactly. It is on the metaphyseal diaphyseal junction. The growth plate is here, and you got the attachment of the synovium here on either side. So this is very important to know for arthritis. Okay. Then you got structures around the joint. So we got a synovial membrane which is holding the synovial. Inside is a joint fluid which is mainly gelatinous material. The cartilage, the bone is seen on X-ray. The cartilage is not seen. So what we see is a joint space on X-ray. And then you got a muscles or tendon coming across. So you can see a muscle coming across, or it could be a tendon in knee joint, or it could be extensor tendons or flexor tendon in a finger, and there are some soft tissue, connective tissue around the joint. So you can imagine that if there is a fluid in the joint, there will be bulging of the joint space and the synovium, which you can get bulging out. So that's like a soft tissue thickening and swelling and the joint space. Then you can get some changes around the joint. So you can get osteopenia, which we call, just a terminology is periarticular osteopenia. Is around the joint is called periarticular osteopenia. And then you can get erosions, which is periarticular or marginal. The margins of the joint at the attachment of the synovium is called marginal erosions. That's where the erosion starts in inflammatory conditions. Or it could be loss of joint space and loss of cartilage and things like that. So this structure is very important to know for further discussion as we go on. So moving on from the discussion we had, you can see what I said to you is marginal erosion. This is a synovium. You can see the erosion on the margin is called marginal erosions and terminology based. This is called a bare area where there's cartilage and the attachment is there's nothing, no synovium is called a bare area where there is no erosions actually to start with. That's why it's called bare area, it's empty area, yeah. And this is a joint fluid. So if you can see in normal cases, the erosion, this is marginal on the margins. This is subchondral. This is a loss of joint space. Something happened to the joint margin, which is called destroying it, or it is traumatic, or due to a loss of joint space due to mechanical conditions. And you can get chondral and subchondral. Chondral is cartilage. Subchondral is below the chondral. So it's called subchondral. So initially the changes are chondral, then it leads to subchondral. But when we see on X-rays, mainly subchondral. On MRI, it could be chondral, but in X-rays, they're subchondral. It's seen in osteoarthritis normally, have you seen? And this is seen in RA, the marginal erosions. So similarly, in this one, you can see the erosions are due to uh, at the subchondral level, there is erosion and there's loss of joint space and there is osteophyte. So this is gets in erosive OA. So these erosions are central. This erosion is marginal. So the way you use your terminology is either it is subchondral bony changes, or maybe if it is proper erosion is chondral or central erosion. Yeah. This is cases of osteophyte, looks like osteophyte, but they are more fussy than proper osteophyte. And these are called bony proliferation, yeah, because the bone is overgrowth. And this is case in psoriatic arthropathy. You get loss of joint space, you get erosions on the side, on the chondral surface only. This not very marginal in this case. So this is destroying the bone and causing a pencil-like, and this is more of a, on the other side is more of a bony proliferation and cupping happening. That's in psoriatic arthropathy. This erosion is also periarticular, but you can see in gout. This is just a diagrammatic explanation. We'll go through it later on just to get a view how it looks like. So we'll start with monoarticular arthropathy. Monoarticular, as the name goes, is single joint. Single joint arthropathy or arthritis called monoarticular arthropathy. Just you can see the causes on the screen. Mainly you get gout. Gout is also poly and mono, but it is where sometimes it's early synovitis changes. You can get in monoarticular. You can get PVNS. Then you can is very common in septic like infective arthropathy, which is pyogenic or TB. Then osteoarthritis can be mono or poly, and osteo is divided into primary osteo, which is hypertrophic, and erosive osteo, which is secondary to inflammation, as the name goes. So erosions leading to osteoarthritis is erosive. Osteoarthritis on its own primary is primary OA, which is hypertrophic, and they can be mono or poly, both of them, as we'll see where exactly is the mono distribution. And the other pathologies to remember for mono is any synovial based pathology like synovial sarcomas or synovial osteochondromatosis, synovial chondromatosis. These are all like monoarticular. Yeah. So as we said, we'll go through. This is where the just basic understanding. Now we'll go to the case-based discussion. So this is case number one. Have a look. This is painful swollen knuckle, getting worse for. It is there for a few months, but now getting worse. So now let's see what we see. So you can also have a look on your own what you think. So it is a monoarticular arthropathy. As I said to you, this is an arthropathy involving the MCP joint. Is the joint space looks to me that is still there. So the joint space is not lost, but I can see a scalloping happening here of the bone, and I can see a lot of erosions there. I can see erosions here. I can see erosions here. I can see erosions here. But one thing you can see is there's no osteopenia in the around in the bone. Yeah, the bone is not osteopenic. There's no marginal erosions. So that's what joint space is preserved. There are erosions with sclerotic margins. So what it suggests is something is going long standing. So that's where it is long standing erosive arthropathy with a preserved joint space. So with that in condition, now we knew what is the cause. So this is where it is. So this case, what you can think is okay, is not a cup, is a single joint. So it's not looks like not it looks long standing. It's not a typical appearance. It's not a gout because there's not any erosions on the periarticular margin. Is central. So this case was actually PVNS. So this is pigmented willow nodular synovitis. Pigmented willow nodular synovitis is mainly, as the name goes, is a synovial disease which has pigment and it has hemorrhagic component. Because it is long standing, it bleeds inside, causes pressure erosions and slowly, but it doesn't destroy the joint space. So that's why it's called PVNS. It's mainly commonly seen in more bigger joints like knee and hip, but remember, you can see in the distal joints like in MCP, and remember PVNS as one of the diagnoses how to approach that. And let's see whether we can explain more in a diagrammatic and in a flow chart. So we tried to make a flow chart so about monoarticular. So in this one, we can say joint space was normal. Okay, there could be a loss of joint space or normal. So when we approach normal joint space with erosions there, okay, and there was some sclerosis around the erosions. So it is a PVNS. So this diagram is very important. Keep remembering this diagram. As we go through cases, you will come to know that how can we differentiate from this diagram and can follow a principle on monoarticular. So we can follow just a general principle of monoarticular single joint arthropathy. So joint space is our main criteria and erosion is our second criteria. So in this case is PVNS. Okay. So as we went through it, you can see the joint space was normal, erosions was present, there was marginal sclerosis suggesting to be chronic, there was scalloping present as we said here, long scalloping, sclerotic margins, erosion, normal joint space. So PVNS. The other places you can see is hips and knees and shoulders. Yeah. But remember that you may get in exam, you get in normal practices. It's not very one of the commonest thing, but because it's not so common, you don't think about it. So the reason is have a think. Normal joint space with erosions. There are very few diagnoses. I would say think of gout, think of PVNS. Okay, so these are the two conditions you should think clearly. Gout, the erosions are very different, punched out, and in PVNS, there are more scallopings and sclerosis, normal joint space. So we'll go to the case number two. So have a look here. Case number two, again, painful swollen joint. So here, looking from the other one, now you can see that this is our middle finger. The main involvement is this joint, which is the proximal interphalangeal joint of the middle finger. If you look in carefully, there's a bit of lot of soft tissue swelling here. Yeah, there's a big swelling on which is asymmetrical. Then you can see, I can see there is a erosion here, which is punched out. Can you see hanging basket punched out erosions on the margin? One is here also. The joint space I could still see is preserved because I can see the other joint which is similar and punched out erosion with a lot of soft tissue. So with the principle as we discussed before, so normal joint space, periarticular erosions, there is mild sclerosis in this also because they are also long standing. So this case is gout. Yeah, this is gout, and the previous case was PVNS. So just remember the points we need to show. So now going the flow chart, you got a normal joint space, yes. We got erosions, yes. But in this case, the sclerosis was not much. The type of erosion was punched out, and there's no scalloping, so it is mainly gout. So normal joint space with erosions, we have seen either gout or PVNS. We have seen both cases, and remember how the appearances are. This is very important for you to how to approach. So this is like typical description. How you can see this is like normal joint space. These erosions are described at punched out erosions on the edge. This is more like going towards the, this is a more bigger erosion because it's more long standing. This is all punched out erosion with normal joint space. So to get that is a gout, yeah. And the soft tissue is called tophi, yeah. They can get calcified, they cannot be calcified, but soft tissue helps you in getting to points towards like what type of condition you're looking at because of the gout has more of a soft tissue component also with it. So you got is normal joint space, you got erosions, you got punched out lesions and calcification sometime you can get. So see the diagram which is shows like the red colors are the more frequently affected joints. So we are discussing mono, but remember gout can be mono, can be poly. Gout is both, but you can get mono in single, like you can get mainly in the feet. Grade 2 is very common. But it can be poly or oligo, which is two or three joints. Okay, so that is where to remember. Case 3, I think now I'm giving a chance to see, like, because we have described the mono. Okay, have a look and what you see. So I think we would say that, okay, again, normal joint space, erosions or erosive lesions in the joint. There's marginal sclerosis happening. It happening around the joints on the both side with normal. So normal joint space and erosion on both sides. There's more pressure effect there. I will think of PVNS again. Yes, PVNS. Yes, PVNS. And I think the modality to look at this stage is nowadays we do MRI. And what MRI will tell you is a blood component in the joint, which will differentiate like a darker and a brighter. So mixed component because it keeps bleeding inside. This is where it's happening. It's a pigmented willow nodular. So the pigment in the synoviums are bleeding and they're collecting inside causing pressure. So MRI is differentiating the blood in different components. So you're getting blood which is darker, blood which is brighter, and erosions with a normal joint space. And that's why because it doesn't destroy the cartilage, yeah. So that's why it is PVNS. Again, same flow chart, same principle, and you got normal joint space, you got erosion with sclerosis, with some sclerosis, scalloping is the PVNS. Okay. Now we're coming to case number 4. So this case was having a history, like just you got a history that there was some injury before, and now the patient has a painful swollen joint. So in this case, with the principle of discussion which we have gone through, if I got okay, so we're looking at the joint space. So okay, what is happening with the joint space in here? Majority, if you look at the other joint space, this joint space in the distal interphalangeal little finger is lost. I could not see any joint space. It's lost. Yeah, the bones which you can see normally on this side, you can see the edges of the bone in a normal distal interphalangeal. You lost it. So loss of joint space, and this is like destroyed chondral surface and these surrounding areas of the joint and some soft tissue swelling there. So this is with the injury of before the history of injury, loss of joint space. We would think of what is we'll think of is whether it was a infection. So what is called a septic arthritis. So this is like loss of joint space, and this will all lead to osteo in the end, which is secondary osteo. But this is a septic arthritis, and given the history, you should see if it is acutely swollen, then you can do a ultrasound scan to see whether there's any fluid to aspirate, or if it is already blood test to see the CRP is high, the white cell are high, and things like that. These are all leading to us saying that okay, the clinical picture is more of infection. This is septic arthritis, and this is where it is septic. This is the lateral view of the same one, and you can see the same principle. The joint space is not there. This is lost, and I think the infection has caused erosions here. And what will happen in future? This will lead to, once it's treated, it will lead to osteoarthritis. Remember, in this case, there's no sclerosis. So what that indicates is more of an acute phenomena. So it is happening very rapidly. So it is more likely pyogenic. So this is where it is. I think this is where it is. So looking at our chart, how we go here. So we got a monoarticular. Yes, it's single joint. We saw that the joint space was lost. Yes, it is lost. In this case, we have erosions which was present as we described. So it goes in the septic arthritis because there's no sclerosis and very acute and very rapidly progressing is more pyogenic in this one rather than tuberculous. The other one is tuberculous. We can get even septic arthritis. Okay. So again, coming to case number 5, just for the sake of getting over, going over the whole process, what we learned. And I think in this one, I think you can have a look, and I think majority of you who are now engaged in this now in the lecture, you can say, oh, I know it is PVNS, and there you go, you get full marks, and everybody is very happy because somebody will be now seen is struggling. Oh, you say, oh, I know the joint space is normal. There are a lot of scalloped areas of sclerosis and erosions on either side. They're more like chronic to me. There's some soft tissue thickening. It is PVNS. Get a MR done, and there is the diagnosis. Okay. Again, the same principle, normal joint space, erosions there, PVNS. Okay. We're just going through some cases over few times, because this PVNS is not one thing you see very commonly. And once you get into the mindset of thinking like that, and this is where you will never miss it. And I think this is where it is like normal joint space with erosions, gout to PVNS. We know how to differentiate now, yeah. So this is where our more mainly was to how to differentiate both gout with PM and PVNS. There we go. So case number 6. Let's go for it. Again, oh, this is a great toe involvement. Yes, definitely. There's erosions which I can see punched out on the periarticular margin. I can see the joint space normal relative to amount of joint disease. This is a joint-based disease with erosions, soft tissue thickening, or dense soft tissue swelling, which is there. There are erosions somewhere here. There, I could see some erosion in the other joints also, but this is mainly involving this. So this is, we are considering still monoarticular, but this is involving other joints. So this is a case of gout. I think now you know exactly what we're talking about. So we saw PVNS, we saw gout. So we got 6 cases so far with normal joint space and erosions. Yeah. So we are very confident like this is gout. Means you can even say that there's some punched out erosions here, and they do involve. Gout will involve mono or poly, but gout is very notorious for grade 2. So going back with our flow chart, what you saw, normal joint space. Yes, yes, yes. So erosions, yes. And it was not much sclerosis, punched out, type of erosion, gout. Okay, some more examples just to show you. This is a very typical punched out erosion. This is more of a typical. And wherever you get in exam and all, just make sure you describe. You say, oh, normal joint space. You say it's a erosion type of erosions, some soft tissue swelling, and you are whether you, because it can involve other joints. You look for other joints, and there we go. So you can sometimes, not necessarily all the time you have to do ultrasound, but some cases where it's more of an acute phenomenon and you don't see much erosions, ultrasound can pick the erosion better. So this is the cartilage, and you can see the erosions here, and this is normal cortex again, which is the same thing here. So you can see erosion. Normally this should have come till the end of here, yeah. So this is erosion with some soft tissue thickening around it, which is called tophies, yeah. Ultrasound is okay. You can do a dual energy CT scan nowadays for the crystal arthropathy. Where it's monosodium urate crystals to see in gout, serum uric acid levels, and things like that. So the main approach is how to approach that. So as we said, gout could be mono or poly, and you can see the distribution of it. Now the one with the red ones are showing that the common one, as I said, toe. Yeah. And mainly the clinical diagnosis with you check the serum uric acid level. That's the main thing to check whether it's raised or no. And is supported by joint aspiration. If suppose there is a clinical dilemma in these cases, then you can do aspiration. Sometimes nowadays we can do dual energy CT if you have the software to have two energy in the CT where you can differentiate and characterize the beam to see whether there's crystal, and it does give you monosodium urate crystal deposits. These are very good in cases where there is a diagnostic dilemma and clinical picture is not very clear. So dual energy is coming up, but not everybody has it. Is a chronic disease. So the serum uric acid is going on for a long time. By the time you get X-ray findings, it is quite late. So these are picked up very in the preclinical stages also. So if you're getting a late stage, like the patient is not presenting or is getting carrying on with the pain, and then suddenly it comes with a very acute insult to the joint. So remember, 4 to 5 years down the line, the X-ray changes happen. So we go to the case number 7, where we can see now. Here we can see the joint space is lost. This is again proximal interphalangeal joint of the middle finger. Joint space is lost, but it's a bit of a marginal sclerosis, and there's more of a new bone formation and osteophyte. There's no erosion as such. These are all osteophytes, yeah. So this is osteophyte, 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 osteophyte. There's no erosion. There's no density changes. There's very mild soft tissue thickening around it, and you can compare with the other joint, which is a normal joint space. So loss of joint space and marginal osteophyte, and this is where we can see orthogonal view, the other view to see, because very important. Totally different view here, that you can see proliferation of the bone rather than erosion. So loss of joint space with proliferation of bone and osteophyte, and then you can say, oh, what it is. I know that we have seen the two cases. This is totally a different case, and this is more of a osteoarthritis. So going to the flow chart, where we'll end up here. So loss of joint space. We're moving on to the different branch of our flow chart. We discussed normal joint space. Now we're discussing loss of joint space. And yes, erosion there? No, there was no erosion as we described. So it is called non-erosive OA. Non-erosive OA means there's no erosion, but osteoarthritis. These are primary arthropathy or OA, and these are called like a hypertrophic OA or primary OA. Yeah. So there is one more OA called erosive. We'll go through it later on. Case number 8. Oh, that's easy one. I think so. Many people can say, okay, we've seen it. The patient looks like some chronic disease. The bones are very slender. It could be either a patient with a stroke or any other deformity which is not using the limb. That's why the bones are slender and osteopenic. But the main pathology is this joint space is normal, but a lot of opacity surrounding the joint, which is very clear cortex. So those who have seen once, they'll know this is called multiple loose bodies osteochondromatosis. So this is synovial osteochondromatosis. And in exam, if you get, these are like a aunt mini, and this is cases you should definitely know very quickly and move on. So synovial osteochondromatosis. So now we move to case 9, very painful sore groin. And okay, let's see what we see now. uh, you can have a time to look at it. You can see that see what is happening. The joint space is lost. Okay, I can see the joint space is lost more medially. The head looks very irregular. I can see a lot of bone density loss around the joint. So in all the periarticular area, there is loss of bony density compared to the rest of the bone. We can see some erosions happening here, and this is destroying the medial surface of the articular cartilage, bone density, some soft tissue swelling. So as we go with that, with the loss of joint space and bit of a bone density loss, some erosions on the chondral and the subchondral margins, we would say that is this, I would suspect, is this an infection going on? So we have seen that in our flow chart how to approach this. So now we got a loss of joint space and periarticular osteopenia and irregular chondral margins, subchondral changes. It is septic arthritis, and we have seen it, whether it's a pyogenic or TB is debatable. You need a history, you need blood parameters, you need to examine the joint fluid. So this is where it is. So you can see other case related to the same pathology. In this case, you see this is more of a chronic phenomena where you can see that the bone is more sclerosed, destroyed, flattened humeral head, and this is like avascular necrosis of the humeral head. Joint space is still lost. There's a bit of a sclerosis and scalloping, but this is not same as that. So this is, in this case, is a joint destruction, but a chronic phenomena because of AVN and sclerosis. So this is a tubercular arthritis rather than pyogenic. The similar was, this was an early stage of TB, and I would say this is a late stage of TB where you can see the changes happening. Yeah. In exam, if you get some of these cases, look for lung changes to maybe a clue whether there's due to some tuberculous focus in the lung or not. And this is very important. Okay. So going through a flow chart, again, loss of joint space, yes. Erosions, yes. And it is Tuberculous arthritis, as we have described, but it's like as arthritis, yeah, it is infective arthritis. So, looking at the discussion of monoarticular arthropathy, you can see a patient with acutely swollen knee. You can see that this knee is very swollen. There's loss of the contour, and on the X-ray, you can see soft tissue swelling, normal joint space, some osteopenia, and it just came acutely. So this is like more of a radiologically and acute synovitis cases. Synovitis could be due to anything: the insult, post-viral, infective, non-infective, which is an acute phase of infection or inflammation of the joint. Yeah. So normal joint space, some osteopenia, and soft tissue swelling. And it's very clinical diagnosis. To be fair, this radiological, but nowadays ultrasound is more of a useful thing. But if you get something like that with swollen, think of acute synovitis. Okay. So normal joint space, but no erosions, as we seen in the flow chart, acute synovitis. So now we have worked out that you can work out that this chart of monoarticular is very important for you to wait to approach it. The main approach is joint space, and the second big is erosions. Yeah. And this is where we go with the monoarticular arthropathy. So as we discussed, there was no erosions, and the joint space was not lost, and there was some soft tissue swelling which was correlated clinically. Yeah, okay. So now, once we have seen many cases of monoarticular arthropathy, now we should have a bit of a summarized approach to it. So if you get a monoarticular arthropathy based on joint space narrowing, you will have an approach. If it is a yes or no, erosion, yes or no, pattern of erosions, type of erosions, punched out or scallop or sclerosing, or articular and subchondral, then is there a sclerosis of the joint, or it is osteophytic or due to sclerosis and osteophyte formation, and look for soft tissue, which is like soft tissue swelling and tophi, whether it is calcified or not. So that is where you should approach joint space, erosive pattern, sclerosis, yes or no, soft tissue, yes or no. Yeah, this is where you should keep in mind. And I hope even if you get this in your routine practice and your mindset, that I will look at joints where I look at erosions, whether there's sclerosis long-standing or acute, and whether there's soft tissue, you will definitely come to a diagnosis and a very good approach on your patients. Definitely, clinical presentations are very important. How long is the history? Whether it's a chronic history, acute on chronic history, like in gout, is very common to get acute on chronic presentations. Then blood pictures, you got ultrasound when you need to, you got MRI when you need to. So this is where you should approach monoarticular. But I would still say X-rays are very, very important to approach arthritis. First line of the investigation should be X-ray after the clinical picture, and then take it from there. Okay, so now we'll move on to poly. Poly, as the name goes, is multiple joint involvement, and this is a very wide area of involvement where you can see the possibilities are like very commonly inflammatory arthropathy like rheumatoid, psoriatic. As we see gout, we see mono and poly. Osteoarthritis, both erosive and primary, can be poly. It can be mono also, primary, but it's poly. Connective tissue disorders is a very big variety like SLEs and scleroderma and other things. So all the connective tissue disorders, and there are other conditions we will go through like hemochromatosis, which is also very important to know on based on if your exam going. And sometimes you can get cases where you can pick it up with the people. They are very characteristic finding for that. So case 11, we'll go through it. So let's see whether you can approach this. So you got both hands, right and left. You got changes in the proximal and the distal joints. So you can see the changes in the radiocarpal intercarpal joint on this side, And you can see changes on the other side also. The changes slightly different and asymmetrical, but there are changes. Then you got changes. If you look at this one, there are proximal joints and you got distal joints also. Okay, and you can get this. If you look at this, if you look at, there's a lot of symmetry happening in the joints. Like if you look at this index, this middle, and this ring, there's a bit of symmetry versus asymmetry. Okay, so what you can see is there is a periarticular osteopenia happening everywhere. You can see a typical loss of bone density around the joint. So this is periarticular osteopenia. You can see some soft tissue swelling also. Okay, so there are a lot of joints involved, but some are showing more chronic and some are more acute. So you got loss of joint space in the radiocarpal. You got erosions, new bone formation. You got distal radioulnar joint involvement. I can't see any line between the carpals. So loss of intercarpal joint space, both proximal, distal row. Okay, this is loss of joint space, lot of definition of the joint. Now we'll look at the erosive pattern. So this is like we have seen the diagram where the synovium, these are all marginal erosions, yeah, happening on the joints. You can see marginal erosions. You can see marginal erosions and everywhere marginal erosion. Loss of joint space, marginal erosions, periarticular osteopenia, soft tissue swelling, very common. In this one, you got osteopenia and some erosive changes, rheumatoid arthritis. Okay, the thing to remember is loss of joint space and erosions, and here it is symmetrical and asymmetrical pattern, but it's more proximal and distal. This is typically RA. So this is RA. So rheumatoid arthritis is an inflammatory condition. Rheumatoid arthritis, which is more proximal and distal. So if you look at this other cases, again slender bone osteopenia, there's a deformity in this. Have you seen the deformity? So this is like happening is this is flexion at the MCP, extension at the interphalangeal proximal, and again a flexion. So if you look at this diagram and why this deformity is happening, but the joints is not as such involved, it's mainly the deformity in this one. And the deformity is due to subluxing tendons. The tendons which are supposed to keep them straight have got subluxed, both flexor and extensors, and this is where they are causing deformity. And as we know, the way the deformity looks like, it is the way the deformity looks like, it is called swan neck deformity. Yeah, so it's a swan neck deformity. Again, similar picture, and you can see the way and how the clinical picture is here. Exactly, flexion, extension, flexion. This is what we saw in X-ray. This is what happens in rheumatoid arthritis. It's called swan neck deformity. So on the pattern of the joint involvement, erosions, deformity. Now you can imagine why we're coming through. So these are all the criteria where you can see helping to know what the diagnosis is, isn't it? Yeah. So now we look at our flow chart for the polyarthritis. Okay, so polyarthritis, you can see a flow. It's slightly busy chart, but if you look at on the left hand side, we got main criteria of erosion, you got distribution where it is proximal or distal, you got symmetrical or asymmetrical, we got deformity as we discussed, you got soft tissue, and you got how the osteopenia is. So these are the main criteria 1, 2, 3, 4, 5, 6. So these are the main criteria where we can now start evaluating our case. So the case we saw had marginal erosions, it was more proximal and distal in that case. The symmetry was there. The deformity was swan neck deformity. There was osteopenia. So it just fits into the criteria. So these flow charts will help you to get to evaluate your condition. The main thing for you to remember is patterns. Yeah, distribution, erosions, deformity, soft tissue, osteopenia. Yeah, this is other case where is deformity is at the proximal interphalangeal joint or flexion, loss of joint space, some erosions, and this deformity is again due to the joint involvement with tendon subluxation in a single digit, and is called Botonius deformity, and is also typical for rheumatoid arthritis. So we saw swan neck, which is more extensive deformity, and when a single digit, you can get Botonius deformity. So just going through RA. RA is proximal distal, both hands and feet. You can see it can involve bigger joints, larger central joints like knee and hips, and elbow and shoulder when the disease is more chronic, but it starts with hand and feet distal. Middle age, common in female. Look for rheumatoid factors, CCP, whether it's positive, often they are positive, and the pattern of distribution. So once you're suspicion on radiographically, you can ask for whether look for rheumatoid factors, blood parameters, antibodies, and things like that. Yeah. So case number 12, coming to poly again. Let's see what we see here compared to the previous case. This is also poly. How to approach this one? So you can see the involvement is both uh, proximal and distal, but I would say this is mainly a distal joint here. So I could see that all the proximal interphalangeal, all the distal interphalangeals are involved. Pattern is slightly symmetrical. So how look at one of the joints now. What do you see? You see a joint space is lost. You don't see any erosions. You see osteophytes around. Can you see the osteophyte coming out? There's loss of joint space everywhere. You can see osteophytes, not much of a soft tissue swelling. Even in this interphalangeal joint of the thumb, you can see the same pattern. And with this non-erosion, loss of joint space, and this is again, so as we've seen, joint space loss, marginal osteophyte, and degenerative changes, no osteopenia or erosion. So looking at a chart, okay, so there was no erosions. The distribution we knew. So which came as this came as OA changes, osteophyte, distal. No, this was not very much as this one, and there's no osteopenia. Okay, so this pattern fits into uh, primary OA, yeah, non-erosive OA. Osteoarthritis distribution, as we've seen, proximal and distal, very notorious for the base of the thumb, interphalangeal joints. Sometimes it gets difficult when there is a chronic inflammatory condition leading to OA, which is erosive OA, which we will see later on. This is a primary OA, yeah? Remember that. So this is non-inflammatory destruction of the cartilage, and it's primary idiopathic condition. There's no inflammation, so it's called primary. Can be due to either trauma to one of, if it is one or two joints, or it is in a larger joint due to weight. Yeah. Case 13. Have a look at this one. So in this one you can see, look at this one, this joint, this joint, asymmetrical. First of all, I got it. Oh, okay, asymmetrical. Loss of joint space, yes. The joint surface is destroyed. The erosions are on the joint surface and slightly on the margin of it. So this is marginal but on the joint surface, and spurring of the joints. And some of them give me a cup and pencil appearance, asymmetrical. Slightly different presentation here, which is on the early stage, some erosions. But this joint, but if you look at the other joints, you know the diagnosis of, we're looking at a polyarticular arthropathy, which is inflammatory. And you see periarticular osteopenia is not there in this. So that's the main thing to remember. No periarticular osteopenia in this. Not much of a soft tissue going on. Cup and pencil. So this is more of a psoriatic arthropathy. Yeah, psoriatic arthropathy. This is again inflammatory and psoriatic. So in early stages, you can see the erosions are mainly on the edges of it, and there is more of a new bone formation like what you get in enthesitis where the tendons are attached. Because this is psoriatic arthropathy or seronegative, you can get like in writers and all, you get more of a fluffy appearance at the attachment of the synovium, yeah, or the ligaments. So this is where it is, and joint space is going to loose. And this is the way the pattern is distributed. So they are very close reactive, as we say, it's called writers was called now it's called reactive arthropathy. It's non-infective, but this is inflammatory. And its history is very important to differentiate the two conditions. And in writers or reactive, you can get genitourinary type of origin of the infection, yeah, which is more of a reactive process to the joint, not directly infective. But psoriatic arthropathy. So looking at our pattern, cup and pencil erosions, distal, non-symmetrical, and no osteopenia. Yeah, you got the main points, and is psoriatic. Yeah. So carrying on from the before, this is again cup and pencil appearance. Can you see? Acrosteolysis, loss of the distal phalanx. Cup and pencil, typical cup and pencil, slight deformity of the joints here, and so the what happens in psoriatic arthropathy? We got Sonneck and Bottinus in RA. In psoriatic arthropathy, when it's very aggressive and in the late stage, you get a deformity called arthritis mutilans. It's a rare condition. Only in 5% of the patients on psoriatic you get this stage. Yeah, it's not very common to see. And mark osteolysis, cup and pencil, shortening of the digits due to the deformity and acrosteolysis. Okay. So just remember arthritis mutilans, just for people who are taking exams or to use this word is more of a uh, good thing for you, for exam point of view. But day-to-day practice is mainly what you diagnose. Yeah. One more example of psoriatic arthropathy in a feet. You can get a typical cup and pencil. So the lesson we are learning is polyarticular arthropathy. If you see cup and pencil, don't even think anything. Just do mention psoriatic arthropathy. Ask for history, and you will be there. Yeah, cup and pencil, psoriatic arthropathy. This is where it is. And if you look at the main pathology, there some of the joints can lead to secondary OA changes. You can see here. So in our pattern distribution, cup and pencil, distal, non-symmetrical, arthritis mutilans, and no osteopenia. No osteopenia in psoriatic, osteopenia in RA. So again, distribution pattern, both proximal and distal, you can see. And it can involve, because it's a seronegative, it can involve the spine and SI joint. It can be symmetrical, asymmetrical, changes like that. You can read through this, more of a description for yourself, what is associated, what to look for, what are the other locations. You can pause it and have a look and read it through. Yeah, okay. So now coming to summarizing the pattern of poly which we saw, you can see osteo pattern, distal can be proximal, rheumatoid proximal and distal, psoriatic proximal and distal. But the way to differentiate is erosive pattern, osteopenia, distribution, symmetry, yeah, between the psoriatic and rheumatoid. So go for the chart, look at all the point, erosion, distribution, deformity, osteopenia, and symmetry. Yeah. This is where you go psoriatic and rheumatoid. Okay, very, very important. And read through the text. Case number 15. Yeah, we're moving on now from inflammatory to slightly different pattern. So now let's see what we see here. Okay, so this is interesting. I can see there are two joints which I am not very happy. One is this middle finger MCP number 3 and number 2. Slightly number 3 and 4 also gone. So what I see is loss of joint space, yes, in these conditions. There is some osteophyte here, and so what's going on? Okay, there's loss of joint space, some osteophyte here. Looks to me whether this is an osteoarthritis due to some condition or not. But why you're getting hook in one side here? Don't see anything obviously like a destruction articular, but hooking. Yeah. So in this case, the teaching is if you get a hook osteophyte in second, third, and the joint involvement MCP, think of hemochromatosis. Look for the TFCC, whether it's calcification, because these are all iron deposit in the soft tissue, uh, and the chronically iron deposit disorder, which can cause calcification and hook osteophyte. Involvement of MCP second, third, fourth, fifth. Second, third, fourth is common. Okay. So hook osteophyte and PFCC is your clue. If you get this combination, in exam going students, definitely these films will be shown in exam, and I don't think you can spare. Oh, I can see normal joint spare, I can see hook osteophyte, I can see TFCC, it's hemochromatosis. You'll really fly with that diagnosis and get good marks. Okay, and this is where in normal practice look for serum iron level. Yeah, if you find this, ask for serum iron level, whether there is hemochromatosis present. Yeah, a descriptive diagram, normal joint space. You can get decreased joint space, normal joint space here. This is decreased. You can get osteophyte and look for TFCC. So this is a clue. So in our flow chart, no erosions. Yes, no erosion. Proximal, yes. Symmetrical, no. Hook deformity, yes. TFCC calcification, yes. Sometimes you can get osteopenia in this one, half of the cases. So is hemochromatosis. Okay, now flow chart. Remember that. Case 16. Looking at this case, okay, what you see, okay, you see a lot of bone is osteopenic. Yeah, agree? Okay, bones are osteopenic, but the main thing you can see is they're all deformed and deviation of the fingers, all deviating to the ulnar side. Yeah, if you see the deviation to ulnar side and osteopenia, I can see that it's like soft tissue thinning for the hand, ulnar deviation. This is all comes into condition called Jacquard's arthropathy, and they can be due to SLE. You can get in other conditions, and typical ulnar subluxation and absent erosion. Angstpon also cases you can see this happening, and SLE, and this is all deformity is called Jacquard's deformity. And where we go here, no erosions, mainly distal and deformity, and remember seen in SLE and angstpon. Yeah. So looking at this, this is again we have been through this case before. Loss of joint space, mainly on the chondral and subchondral surface, osteophyte. Symmetry, yes, slightly symmetrical, not totally symmetrical. Distal involvement, yes, distal involvement, mainly the PIP. So this is with our teaching before we have seen, we'll see the flow chart, but this is looks to me osteoarthritis, isn't it? Yeah, this is osteoarthritis. So you got gullwing deformity, which we saw before, which we seen, and we're going over it again. Gullwing is the type of deformity you see, and if you use that for exam going student, you get like you know what you're talking about. Once you say gullwing, you know you're talking about osteoarthritis, or it's also called sawtooth. Yeah, like a sawtooth, yeah, on the edges of the bone. That is in osteoarthritis, erosive OA mainly, yeah. So this is where you get an erosive OA. So this erosions leading to osteoarthritis is erosive OA, yeah, okay. Again, erosions Gullwing type, distal, symmetrical, no osteopenia. Yeah, the flow chart where we went through it. Yeah, for remembering the points. Erosion, distribution, symmetry, deformity, osteopenia. Yeah. Again, the pattern of distribution mainly distal. Can you see on the diagram representative? And this is where you see very commonly. Just to describe and would clarify, this is more of a typical appearance of Gullwing. Typical sawtooth. Can you see sawtooth? Edges of the tooth saw, and it's like a bone are grinding on each other. They are like fixed. This is Gullwing. Yeah. Erosive osteoarthropathy. So now coming to our again a summary chart based on joint distribution. Proximal, distal, poly. Whether it's proximal or distal. As I said, distribution, erosion, cup and pencil, psoriatic, periarticular, RA, Gullwing, erosive OA. Yeah, this is where you have to see what type of erosion, where it is, type of distribution. When it goes for deformity, swan neck, RA, botaneous RA, mutilans, psoriatic, soft tissue calcification, connective tissue disorder, mainly in scleroderma. Yeah, hemochromatosis and gout or tophi calcification. This is where poly can land up. Distribution, erosions, deformity, soft tissue patterns of it. Yeah. So this is just to remember how to approach. We go to miscellaneous conditions. Some of them just quickly go over it because they can come or cannot come to you routinely. So this is case 18, soft tissue calcification pattern in the digits of the thumb and the index finger. Acrosteolysis, one of the digit is missing. Can you see? 1, 2, 3, 4. Number 3 is missing, which is the middle finger. And soft tissue calcification. So this is mainly, as we've seen the flow chart, this is a connective tissue disorder. This is scleroderma. I think that's why acrosteolysis is happening. So this is also called CREST syndrome. Yeah. Have a look on the slide. You can see what CREST is: calcinosis, Raynaud's, esophageal motility disorder, sclerodactyly, and telangiectasia. Yeah. So patterns of soft tissue calcification and acrosteolysis. Okay. CREST syndrome. Exam going student. Remember that. And have a look at this slide. Yeah. 19 case. Now what you see, case 19. Look at this case. This case, what you see is, okay, joint space is lost. I can see widening of the condyles. They are a little widened, but the intercondyle notch is very wide. Yeah, very wide. And loss of joint space. Osteopenia around the joint. Periarticular osteopenia, widening of intercondylar notch. And your teaching must be like that. Okay, if you look at that, okay, you get periarticular osteopenia, widening of the condyles, intercondyle notch. It's called fenestra triad. Didn't you know that? Yeah, yes, it is. So you get in acute synovitis or chronic synovitis cases going through. And what can be the conditions? You should know that. Yeah. So one I would think of is hemophilia, which is one of the common condition to get this chronic repeated synovial inflammation or insult. And second is TB. Yeah, TB also can look like that. Mr. Pratt. This is TB and the other condition. Yeah, in young ages, to think of JIA. Yeah, so JIA is there under in the PH group and hemophilic and early TB. Yeah. So here you can see it is periarticular osteoporosis. You can go through that epiphyseal enlargement as we discussed. Loss of cartilage can have widening on intercondylar notch. Yeah. Yes, femester triad in that one also in hemophilic arthritis. You can see the distribution. You can get pseudotumors, you can get osteoarthritis. These are all like a chronic secondary complications of hemophilic arthritis. Yeah. So, hi, yeah, this case 20. So, have a look. If you look at this case, you look like it's proximal and distal. Some of the digits involvement we have seen that is very good periarticular osteopenia, erosions in the marginal erosions. You can see, you can look like they look like RA, isn't it? Like, they hear the erosion of the styloid process, distal radial joint, loss of intercarpal joint space, periarticular osteopenia. So in this case, if this is a young person, then think of juvenile idiopathic arthropathy, yeah, JIA. Very important to think about that. It's similar to RA, but think of the age group, yeah. So again in the flow chart, erosion distribution, the pattern of erosion, it was both distal and proximal, non-symmetrical, and with osteopenia. It's juvenile. So as I said, RA, they are very overlap. The only difference is you have to see the age group. Yeah, juvenile idiopathic (JIA). Think of that. Have a look at this slide. You can go through the text if you want to know more about it. Okay. So this case is a chronic recurrent joint swelling. So you see the joints are normal. Okay, everything looks normal to you, and but then you are looking, oh, I see joints normal, I cannot see any erosions, I cannot see any soft tissue calcification and the distal areas. Then you go to proximal, and then you see this or TFCC calcification. Yeah. So this is with a painful joint and TFCC. You call them CPPD, crystal deposit disorder. Okay. This is like a pseudogout. Yeah. Remember that pseudogout. So these are also called chondrocalcinosis or crystal arthropathy. You mainly get in knees, and pseudogout can be due to crystal deposit. Sometimes the chondrocalcinosis can be age related and in osteoarthritis. Yeah. Meniscal calcification. You can see, as we've seen in the before, you can see the TFCC, which is fully calcified. Same if you see knee is very easy to see, and this is where it is chondrocalcinosis. So going through this one, CPPD is very important to know. It's proximal involvement and can have larger joints. Mainly you see knees and other joints, but you can see in wrist also. So you can look at the text here. What are the difference between pyrophosphate arthropathy and chondrocalcinosis? Because chondrocalcinosis can be just asymptomatic and due to age related, but pyrophosphate is deposit of the crystal, and acute inflammation is pseudo-gout. Yeah, they look clinically like gout. That's why they're called pseudo-gout, but actually they are not gout. Yeah. Okay. Go to the text and have a look. So this patient with diabetic history, and I think you all must have seen these cases many times. Got destruction of the proximal subtalar joint, uh, deformed bones, density is not as much lost. There are a lot of disorganization in the joint. The density is preserved, deformity is there, vascular calcification gives you a clue of a diabetic foot. And this is where it is Charcot's arthropathy. Yeah? So soft tissue swelling is there. It could be acute or chronic, and it can be acute and chronic. Mainly it can involve the mid-tarsal, mid-foot joint or the subtalar joint. Yeah, sometimes it can involve the ankle joint also, but ankles are relatively preserved. Charcot teaching wise, 5Ds: preserved density, destruction, debris due to the destruction, Distension is due to effusion, and disorganization when with malalignment due to chronic colic. This is mainly in diabetic, very common. You can get in any other neuropathic conditions. Yeah, syringomyelia and all the stuff you can get when the patient don't feel what's going on, and chronically repeated insult of the joint leads to neuropathic arthropathy is called Charcot's. For exam purposes, very important to know what are the Charcot's presentation in 5 days. Yeah, some miscellaneous condition in spine. If you see fused spine and the disc is calcified, bone are squared up, vertebral bodies, ALL, the anterior ligament is calcified, disc is calcified, syndesmophytes, lateral ligaments calcified, they look like bamboo spine, the SI joints is fused. This is like a bamboo spine, Angspon, okay, ankylosing spondylitis. You can see the iliolumbar ligament calcified, SI joint gone, changes, but the main joint, hip joints are okay. So this is AS. Ligament calcification, interspinous, like a line. Yeah, you can see a clean line. This is where the clue is. Ligamental calcification is Angspon. Yeah, so you can get have a look at this slide. The distribution, main joints, bigger joints, spine, mainly spine and SI joint. Yeah, and look for shiny corner on plain film like a white because of enthesitis. Bamboo spine is late stage. Yeah, sacroiliitis can happen. Yeah, these are the things you need to know. Have a look the text and go through it for Angstrom. So in the end, this flow chart is very important to know on the distribution, erosions, pattern, deformity, soft tissue calcification, and erosion. Again and again, you're going through it, but this is the way you differentiate your conditions. Yeah. So go to the flow chart, have in the mind if you're doing your routine practice, if you're doing exam, if you're routinely reporting hands and feet and other x-rays. Yeah, you need to know. Yeah. So erosions, yes, where it is, how it is. Distribution, whether it's more proximal or distal. Whether the osteopenia is there or not. Yeah, this gives you a clue of what it is. Yeah. And soft tissue calcification gives you a very good clue of gout and hemochromatosis. Yeah. And connective tissue disorders. Yeah. This is where it is. Soft tissue is a very rare component. Okay. So just going through, we got this a good diagram from Radipedia just to show you, we recognize that and show you the way the pattern is. Psoriatic arthropathy, you can see the blue line showing the way the joints are involved. Mainly the distal interphalangeal, proximal interphalangeal, sometimes the TFCC and ulnar styloid area. Yeah. Pyrophosphate is called CPPD. We saw is mainly proximal, wrist, TFCC, MCP. Okay, this is look for TFCC calcification. Yeah, pyrophosphate arthropathy, which is pseudogout. Yeah, rheumatoid, distal and proximal, but mainly more proximal. It doesn't involve the very distal interphalangeal joint. Yeah, MCP very common, wrist very common. Proximal involvement symmetrical in about 60-70%. It could be symmetrical, female common. Yeah, so and pattern of erosion, osteopenia, deformity, location, rheumatoid arthritis. Gout, have you seen it could be mono and poly? Remember in gout, normal joint space with punched out erosion. Whether it is one joint, multiple joint. The additional finding of soft tissue swelling and tophi and a calcification gives you an added finding to it. Yeah, okay. Erosive OA you can get due to erosions. Seagull, gull deformity, sawtooth deformity is all goes into erosive OA. Yeah. Osteo, the pattern of erosive and osteo is same. The way this is non-erosive, the other one is erosive. Otherwise, the pattern is same. Okay. So this is more idiopathic. The erosive is more of erosions due to inflammatory and secondary OA. Yeah. This is where you should know. Yeah. So we would like to appreciate Radipedia and Radiology Assistant because we have used some of the materials from their sites to give a guidance on this presentation. We thank both the resources we used, and they were very lovely. I hope that this has helped you in coming to. I know it's a bit of a long presentation about that, but it helps you in getting clue about how to approach arthritis if I see mono and poly, how I should go ahead if I'm giving exam, how to approach it. Thank you guys for your attention and good luck for whatever you do and hope it helps. Thank you. Bye.
Please find the link for the future Radiology University courses below. Join our WhatsApp or Telegram group to stay updated about the release of new videos, Viva tips, and monthly free FRCR Viva sessions. Oh, and I almost forgot. Find our free book about FRCR 2B tips in the link below.